Ladies and gentlemen, thank you for standing by, and welcome to the COVID-19 media briefing conference call. At this time, all
This is a WDIO News special report.
Today's conference is being recorded. If you require any further assistance, please press *0. I would now like to hand the conference over to your speaker today, Mr. Mike Schomer. Thank you. Please go ahead, sir.
Areas of interest for her group. After those updates, we will open up for questions from reporters on the line. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. I'll start with the data brief, as usual. Globally, as of early this morning, we were at more than 4.8 million cases around the world and 318,000 deaths. In the United States this morning, we reported more than 1.5 million cases and just under 90,000 deaths. Here in Minnesota, we added an additional 660 confirmed cases yesterday, bringing our new total to 17,029 laboratory confirmed cases in Minnesota. The case doubling time does continue to lengthen a little bit. It's at 13 days now to double, which is up from a little over 10 days to double a week ago and 8 days to double the week prior. We keep focusing on that case doubling rate as a measure of how quickly the epidemic is growing relative to the underlying volume of cases and population. We are tracking 8 counties now with food processing plant outbreaks. And while the number of cases in these counties per 100,000 of population puts the incidence of COVID in some of these areas on par with Hennepin and Ramsey and puts them on a par with some of the fastest growing counties in the nation, these 8 counties currently represent only 12% of the new cases day over day. So that is an indication to us that hopefully the situation is stabilizing in these communities. In terms of the mortality rate, unfortunately, again, yesterday we had a report or a confirmation of 17 deaths from COVID-19 in Minnesota. 9 of these deaths were in Hennepin County, 2 each in Dakota and Ramsey, 1 each in Clay, Itasca, Kanabec, and Olmsted. Age-wise, this includes 1 person over the age of 100, 3 in their 90s, 4 in their 80s, 3 in their 70s, and yesterday 6 people in their 60s. Of the 17 deaths yesterday, 13 occurred among residents of long-term care facilities. Our total now is at 748 deaths in Minnesota. In terms of hospitalization rates, I will just note that we added 57 additional people into hospitalization yesterday. We're currently at 545 patients in the hospital. That increase of 57 is our highest day-over-day increase in numbers of folks hospitalized. Interestingly, the number in intensive care remains the same at 229, which likely reflects some people moving into and out of ICU level care. But notable that we had a significant jump in hospitalizations yesterday. I'd like to remind everyone that today To remember and mourn and honor the lives of those lost to COVID-19, the governor has ordered that all United States flags and Minnesota flags will be flown at half staff at all state and federal buildings in the state of Minnesota from sunrise until sunset today, Tuesday, May 19th, 2020. This will be repeated on the 19th of every month through the remainder of the year. And as I just mentioned, to date, we've lost 748 of our family members, friends, and neighbors due to COVID-19. And we know that deaths due to COVID-19 are disproportionately affecting indigenous communities, people of color, the homeless, the elderly, people in long-term care, congregate care facilities, individuals with pre-existing conditions and disabilities. Now more than ever, we need to come together to support those most vulnerable and to honor and support the families of those lost. I'd like to mention some statistics related to laboratory volumes. We had 5,229 tests processed by all the labs reporting in yesterday. Tuesday is typically our lowest volume of the week. Tuesday and Wednesday tend to be lower days of the week. But it's notable that yesterday's volume is higher than a week ago and is a high mark for Tuesdays. And we have quite a few targeted facilities, long-term care facilities, prisons, jails, and other congregate settings in the queue to be tested for the rest of the week. Just want to remind folks again that anyone who has symptoms of COVID-19 can and should be getting tested. And again, when people test positive and or if they feel sick before they are tested or while they are waiting for test results, that means staying at home. It is such a key element of our Stay Safe Minnesota strategy for everyone to do their part, and to do their part observing all those important health guidances as well, which means washing our hands, covering our coughs, keeping that safe 6-foot distance from others. And it's a very good idea to wear non-medical grade masks whenever you are away from your home, remembering that the reason we wear masks is to protect each other. Me wearing a mask protects you, you wearing a mask protects me. It's so important that we all stay at home, as we just mentioned. If you have symptoms and we want you to get tested, it's especially important for higher risk people to continue to stay safe and to practice social distancing and to pay very close attention to that health guidance. I think with that, I will turn it over to KRIS EHRESMANN for any further comments before we take your questions. KRIS.
Thank you, Commissioner. I just want to make one comment, and it is COVID-related, but it takes us back to some of the public health messages that you have been hearing from us for years prior to COVID. And I've mentioned this before, but I want to talk about the concern that we have in the decline in well-child visits that is occurring because of our response to COVID. With the decline in well-child visits, we are seeing a concerning decline in the recommended childhood vaccinations. And so as families are starting to return to the new normal, we want to make sure that you are considering whether or not your child missed an important developmental well-child visit during the time that we have been in our stay-at-home order. And so if they have, please reach out to your healthcare provider and get that scheduled. In addition to vaccination, there are other important developmental assessments that occur and other important tests and evaluations that occur. We want to make sure that even as we are working hard to address COVID-19, that we're not missing the opportunity to prevent those diseases that we know are deadly, but for which we currently have vaccines. So I just want to highlight that, want to make sure that parents are thinking about the importance of getting those visits scheduled and keeping their children up to date with their vaccines. And with that, I will turn it back over to Mike Schomer.
Thank you, KRIS. We'll open it up for questions now, asking again the reporters limit their questions to one primary question and one on-topic follow-up so we can get to as many outlets and questions as possible. With that, operator, we are ready to take questions.
Thank you, Mr. Schumer. As a reminder, everyone, if you wish to ask a question, please press star and then the number 1 on your telephone keypad. If you wish to withdraw your question, please press the pound key. We will pause for a moment to compile the Q&A roster. Your first question comes from the line of Bill Werner from Minnesota News Network. Mr. Werner, your line is open. Please ask your question.
Thank you, and thank you, Commissioner. You, I assume, are aware of the testimony that was just given to the Select Committee by nurses, and Ms. Krinke's response from the Minnesota Hospital Association. The nurses say they don't have enough personal protective equipment, and some lawmakers are saying, specifically Majority Leader Winkler, that the elective surgery needs to be revisited, that the governor's decision on easing that needs to be revisited. What are your thoughts on that?
I'm sorry, I was on mute there. You know, I must apologize. I have not heard that testimony, but I appreciate it. I understand the perspective of the nurses. What I can tell you is that the guidance that we put out for allowing more elective procedures, and we can certainly talk more about the reasons why we felt that was important to begin to make sure that Minnesotans could get more of the care that they have obviously been deferring. But the guidance we put out about that really required that providers have a plan for how they would monitor their personal protective equipment and how they would assure that their staff have the equipment that is required. Now, I will say we know that a lot of the facilities are still conserving personal protective equipment, so we're aware of situations where staff are asked to keep a mask and use that mask multiple days, things of that nature. So we certainly are aware that there's continuing dialogue and pressure around that issue, but we've been pretty clear that the health providers should have the ability to, when they can assure that they've got a plan in place for appropriate use of PPE and conservation of PPE, that they should be able to expand their services.
There was, Commissioner, if I may follow up, there is testimony from a number of nurses in that hearing who say that these standards are being relaxed, that pre-COVID, they would have never been put in a position of using PPE the way that they're using it now. It endangers their patients, it endangers them, and some of the nurses are saying we need openness and transparency. They're saying the president, the governors, plural, okay, and hospitals need to tell people we don't have enough of this stuff, and then action needs to be taken. I'm talking about PPE now, not enough. What can you tell Minnesotans? Do we have enough of this at this point to adequately protect healthcare workers as well as their patients, or are we cutting some corners in some areas?
Bill, I appreciate the question and the reminder that we need to be very focused on the front lines here. And I can just assure listeners and assure the nurses that we will continue to be in close dialogue with the health systems on these questions of appropriate use, conservation, et cetera. I appreciate Commissioner Roberts Davis being on the line to help address this question of what kind of progress we are making in making sure that we do have capacity to support the PPE needs of providers in our state. So, Commissioner Roberts Davis, would you please share a little bit of a situation update on that point? Thank you.
Absolutely. Thank you, Commissioner Malcolm. Thanks for the question, Bill. I was watching the testimony given by the nurses, and what we're seeing in the twice-weekly reporting that we're receiving from hospitals on their inventory is that their inventory is relatively flat. We're not seeing any increases in usage at this point in time, and what we're seeing is that, in general, hospitals have at least 3 weeks of inventory on hand of all items, including gowns, which were difficult for us to source at a point in time. And so, although we have quite a bit of inventory in the stockpile, the warehouse that we've created here for the state, the expectation is for hospitals to purchase through their normal supply chains and then make requisitions for the state when they reach 4 to 7 days inventory. We have the ability to supply their needs as they requisition it, and so we're happy to help whenever we can.
So commissioners are, and that would be my last follow-up here because I know other folks have questions too. Are we at a situation where hospitals are having to ration personal protective equipment, and which is obviously not to the satisfaction of the nurses? They're dissatisfied with how that's happening. Are they having to ration the stuff below what would have been required in terms of standards pre-COVID?
I believe that the hospitals are setting their own guidelines for how PPE is being used. What we see on our end is when they're reaching a certain supply level, they have the ability to requisition, but if they don't reach that supply level based on their usage in the independent hospitals, then we're not seeing that the need is there. And so what they have the ability to do is to provide it to the nurses as it's needed and then requisition the state as they reach low levels.
Thank you, Commissioners. Appreciate it.
Your next question comes from the line of Kent Erdahl from KRIS Television. Mr. Erdahl, your line is open. Please ask your question.
The first thing I wanted to do is just kind of clarify where we were just talking about, because it sounds like, and if you can correct me if I'm wrong, but the CDC relaxed some of the PPE requirements in light of the shortage of PPE post-COVID versus pre-COVID. Is that correct? Can you clarify that? Because that sounds like where some of this is coming.
This is Commissioner Malcolm. Yes, I think that is an accurate statement, that the guidance from the CDC became more specific about the situations in which certain types of personal protective equipment were required for a more selected set of procedures. Chris, I'd invite you to comment too if you have further information.
Yeah, I'll confirm as well that CDC did put together guidance on, how PPE should be used if you're in a position where you don't have all the necessary PPE. So there is guidance to that effect, and it can be used certainly if there is adequate PPE. We want to make sure that people have, all the protection that they need, but because of the situation with the global shortage, there have been changes that have been made in terms of how PPE can be used in this current COVID-19 pandemic.
So if hospitals are using this as why they're carrying out the policies, it sounds like that's where this friction is. Does the state have a position on whether hospitals should be going back to more of that pre-COVID standard?
I think that we have not had a reason to differ with the CDC's guidance on the prioritization and conservation of PPE. One of the things that we know is happening, and it seems like it's a good thing, are the technologies that have been created to allow the sterilization and reuse of some of these things, like N95 masks, for example. Now the procurement of washable gowns as opposed to throwaway gowns at every time. So Commissioner Robert Savis, I'd invite you to comment too on if you've seen anything kind of changing in the types of equipment that are being created in this environment.
Thank you, Commissioner. I think that's absolutely right. We have requisitioned and are hoping to receive some Battelle units, which would allow us to decontaminate N95s and reuse them. We are using washable and disposable gowns in hospitals. We're ordering both of those different types of gowns for their use. We just continue to see tightening in the supply chain. It's not as stabilized as it was pre-COVID, and so we definitely are very cautious about ordering and ensuring that things that we order are coming in, and so we think that it's a both-and situation. The hospitals should continue to use them conservatively to the point that they're comfortable and allow us to continue to find the PPE that we're looking for in the supply chain and bring it to the state.
Okay, thanks. I was just going to follow up because you had also said that yesterday you'd be able to update us on serology testing today. I don't have any follow-ups to that, but if you have any of that information, that would be helpful.
My apologies. I don't think we confirmed that Dr. Linfield would be available today for the serology testing follow-up. She was not available, so we will get that scheduled just as soon as we can. Unless, Chris, you happen to have any additional data from yesterday, but I think we were looking to Dr. Linfield for that.
Yeah, I know that we are receiving serology reports, so they are being reported to us, but we are currently not acting on any of those reports. Our focus right now is on the current COVID infections.
And my understanding is Dr. Linfield will be available tomorrow, so we can plan on revisiting this topic then. Sorry for the delay.
Your next question comes from the line of... Yes, sir. Go ahead, please.
I'm just going to say we're ready for the next question, please.
Yes, sir. Your next question comes from the line of Erin Hassan-Dabe from WCCO. Please ask your question. Your line is open. Right.
Hello, I'm just wondering if anybody is able to get an antibody test. So obviously you went over at the beginning, if you have symptoms, you should absolutely get a test. But what about for antibodies? Who's allowed to, and can you access those in the same places you get the test?
Crystal, I don't know if you have any particular information on that. There's not any official guidance at this point on who is allowed, as you say, to get serology tests. I know some providers are doing that for different purposes. I think we've said on prior calls the evidence is still very much out on what serology tests tell us and don't tell us, such that it's not thought to be really useful information at the level of the individual person, but can tell us some useful information at the population level about the degree of prior exposure. Chris, can you chime in?
Yeah, I would second all of those things and say that there are a number of serology tests that are available, but a majority of them are not FDA approved at this time. So people likely have the opportunity to get tested in many different locations, but we, as the commissioner said, we want to make people aware of the fact that these tests are not FDA approved, that, if there is going to be testing done, we'd recommend that it's done via a laboratory that is doing, an FDA approved test like Mayo or the university, and we would like to start with population data, looking at what does this tell us for the population rather than for an individual, because we don't know what it means in terms of the duration of protection and how much antibody is necessary, what type of a result is sufficient to say that you really have some level of protection, and we don't know how long it lasts. So there are still so many things unknown that we're not actively promoting this for individuals, but there are many, many tests out there that are not FDA approved. So if someone was seeking it, I'm sure they could find it. But as the health department, we're not recommending that at this time.
Yeah, just a quick follow-up then for you, Chris, is what do they show people? So there's so much that's unknown, but basically, from your health department perspective, what would a serology test reliably show someone today?
It really depends on the test. I think you may have heard early on, as we were talking about coronaviruses in general, that there are a number of coronaviruses that can cause a common cold. So, 40% of colds are caused by a type of coronavirus. And so if you have an antibody test that isn't specific to the SARS-CoV-2, to the actual virus that's causing COVID-19, you could have an antibody test and it says, yeah, you've got antibody to coronavirus, but it could be because of that cold that you had last October. So we want people to recognize that the information from these tests, until there's better, I guess, oversight and better information, they may not be getting the information that they're thinking that they're getting. So we want people to have a certain level of caution about this, and that's why we kind of direct people back to the type of testing that has been FDA approved, that is specific to SARS-CoV-2 coronavirus, and that's why we're not actively promoting the many different types of antibody tests that are available right now. If that helps to differentiate. It's not that there isn't a place for antibody testing, and it's not that it won't have an important role, but right now we're focusing on testing for current infection, and then as the strong, serology tests become more readily available, then that's something that will be used.
Thank you.
The next question comes from the line of Matt Sepik from Minnesota Public Radio. Mr. Sepik, the line is open. Please ask your question.
Hi there, Commissioner and Chris. I'm wondering what you think is behind such a large jump in hospitalizations, 57 new hospitalizations reported today.
Well, it's certainly notable. It is a big jump. And I think I would just look to Chris for any commentary on anything that she may have seen in the epi data that would have kind of given us a clue a while back that this bump in hospitalizations might be coming, or whether this is something that we don't have a good explanation for. Chris?
Well, I can't say for certain, but we do know that with COVID illness, we have seen in some cases where the illness has a bit of a biphasic presentation, meaning that people may have milder symptoms initially and then later on develop more severe symptoms. And so it may be that with some of the case, we had some higher numbers of cases reported last week, so days with much higher numbers of cases. It could just be a function of that. But I can't say for certain, but that is certainly something to consider.
Okay. And to follow up, I know you talked last week about contact tracing and the difficulty you've had in finding the infection source for many people. With the hiring of all these new contact tracers that you mentioned yesterday, when do you expect outcomes to improve in terms of figuring out where people picked up the COVID-19 virus?
I think it's fair to say that for many situations, you may not know where you picked it up. We know that it's circulating in the community, and so not everyone, even with adequate case investigation and contact tracing, not everyone is going to be able to say, I got it from Fred or I got it from Frida. It may be a situation in which they honestly don't know. And so we need to acknowledge that we may not find an epidemiologic link even with a strong case investigation and contact tracing team in place. We need to acknowledge that there is community transmission that's occurring. And again, that is why our guidance is so repetitive, which I realize that we say these things between the commissioner and I, we say these things so often, but that is why we're recommending, social distancing, wearing a mask, all these things, because it is in the community, and people can't always, for sure can't identify who has COVID. And so we need to be taking precautions all the time. But I want to be clear that, yes, we have enhanced our team, but even with that, it's not every situation will we be able to identify an epidemiologic link.
Okay, thank you.
Your next question comes from the line of Paul Scott from Forum News Service. Mr. Scott, your line is open. Please ask your question.
Great, thanks. Hi, I've read that people with the virus likely give a larger dose over time to a family at home than they would ever give to a stranger in passing, and it got me wondering if that affects the severity of illness for positive cases who go home to isolate among family in very small apartments or homes. Do we know if the higher risk of poor outcomes in various populations has an SES component, and if that might be related to the inability to isolate at home and avoid giving a stronger exposure dose to your family?
Chris, would you take that?
Sure. That's a really excellent point that you make, and certainly that is a concern, that we know that there are individuals for whom the recommendation to safely isolate is really a challenging one. And so that is why, for instance, when we are looking at doing, mass testing or situations in which, people are being tested, and we think that there may be situations of crowding in their housing, that part of our interview process is to ask if people have the capacity to isolate safely at home. And if they don't, our local public health partners have worked on ensuring that they have options to assist with housing. So, for instance, part of our planning when we were doing the testing in Nobles County was working with Nobles County Public Health and emergency managers, and they had looked into how would they access housing and essential services for people who might need that so that they could safely isolate. I realize that there may be situations in which people, haven't gotten tested or may not be, aware that they have COVID and there's spread that happens within a household. But for individuals that we are reaching out to, that is one of the things that we do ask, is if they feel that they would be able to safely isolate or if they need assistance.
Do you know if the severity of the outcome is affected by the dose? Do you think that's a thing?
So in other words, a dose response. So I spend a lot of time with you and close contact, and so therefore I'm going to get sicker because I had more exposure to you. I think I have not heard that. I certainly know that the more intense exposure that happens in households means that it's more likely that there will be transmission.
Okay. I only ask because that was one of the theories early about the New York doctors that were very young and healthy and that were having very bad outcomes, as possibly they had longer exposure.
And that's certainly a very reasonable consideration. I have not heard that, so I can't comment, but it certainly is reasonable.
Thanks very much.
Your next question comes from the line of Theo Keith from Fox 9. Mr. Keith, your line is open. Please ask your question.
Hi there. I want to go back to the disconnect, which I'm still not completely understanding, between the nurses who say they're having to ration all this equipment, the providers who say they don't quite have enough, and you guys were saying there's a pretty strong 3-week supply across the board, even of gowns, which have been very hard to find. Are the nurses just going to have to live with this for the time being?
This is Commissioner Malcolm, and certainly Commissioner Roberts-Davis, if you're still on the line, I would invite you to comment as well. we certainly hear the tension and the questions around what is appropriate use, what is appropriate conservation. It certainly is the case that what might have been sort of just automatic before to use one-time use and then dispose, that is changing. You know, the degree to which that's appropriate and evidence-based. I think that these questions around sterilization and reuse, there seems to be very good evidence that is an effective way to conserve and reuse. So I don't want to make an overly broad statement about who's right and who's not in this situation. I think there are understandable points of view and arguments on each side. I think our best role is to make sure those conversations are happening between the nurses and the health systems, and to make sure that we are doing everything we can to assist the health systems and the providers, large and small, across the state, to be able to access PPE when they need it. And I just am so appreciative of the work that Commissioner Roberts-Davis and her team have done. It's extraordinary to be even in a position to build up a state-level reserve such as we are, so that we haven't had to be reliant on the federal strategic national stockpile, which is normally what we look to as the first line here in a public health emergency. I'm happy to hear the federal government talking about replenishing the strategic national stockpile. That would certainly help. But what we've done to try to create our own state reserve, I think, is really important. Commissioner Roberts-Davis, anything you'd like to add?
Thank you, Commissioner Malcolm. I think that you absolutely hit the nail on the head with that. Our relationship is with the hospitals, and the requisitioning is coming to us from them. Certainly listening to the nurses today on the health hearing was troubling, disturbing, very heartbreaking stories that we heard, and a lot of empathy for them. But what we're dealing with right now is a situation where the hospitals are trying to balance the ability to get supplies with the need for supplies immediately, and along with that, also anticipating what we might need in the future. And so I think that all of these things become a balancing act, and they're doing the very best that they can to provide what the nurses need today with an eye to the future for what they might need tomorrow.
Thank you. Somebody earlier brought up the restart of elective surgeries. Let me ask that question a little bit differently. Is there any talk of once again suspending elective surgeries, or are they here to stay?
I'm sorry, I was having trouble unmuting Commissioner Malcolm. I think one really important distinction is, to talk about the distinction between elective and medically necessary. I think we have made it perfectly clear that situations may change and we may need to revisit guidance. But I think what we were hearing loud and clear from the public and from providers was a growing concern of very necessary procedures that were being put on hold, not being done, that could have very important long-term consequences for health. So we wanted to make it really clear that professional clinical judgment needs to be applied to make sure that things that need to be done can be done. I think we're always willing to be in dialogue with the providers about how it's going. We can and will kind of dig more deeply into the realities on the ground, on the front line, about personal protective equipment, but if it's necessary to revisit the elective procedure advice and guidance, and I will stress it's guidance, that leaves a lot of both responsibility and ability to local providers to be making those decisions and striking that balance. So, but nothing is off the table in terms of what can and should be revisited.
Operator, we have time for one more question.
Yes, sir. Your next question comes from the line of Steve Kornowski from Associated Press. Mr. Kornowski, you may ask your question.
Yeah, I realize that Director Kelly might not be on the line here, but I'm wondering what you can tell us about the purchase agreement that was completed to buy that warehouse for use as a temporary morgue.
Actually, he did join us, I believe. So, Joe, if you're here, please chime in.
This is Commissioner Roberts Davis. I'll actually take the call. So we did close on the building yesterday. It is a former grocery distribution warehouse in the city of St. Paul on Lorient Street. It's a roughly 71,000 square foot facility built in 1997. We had about a $5.4 million purchase agreement on the building and land. There's also funding for some improvements and some maintenance to the building. Obviously, it'll need some work in order to transition it to the need that we have forecasted for it, but those are the rough logistics around the building.
So what's the total price tag then?
$5.4 million for the building.